What we want to talk about today is we're going to talk about definitions of disc injuries. We're going to talk about the anatomy and physiology related to disc herniations. We're going to go through some evaluation and diagnostic tools and some treatment protocols. What I want you to understand, patients come in. How do you know if they're a disc injury? Or what makes you think this person might be a disc injury? What would you see?
High levels of pain.
Pain.
Radiation in their extremities.
Radiation. We're talking lumbar, down in the lower legs.
Muscle weakness.
Muscle weakness. What's their posture look like? If they're sitting in your lobby and you say, okay, Miss Jones, come back, what's she going to do? She'd be sitting in her chair and she'd go, okay, just a minute. Okay, here I come. How many of you have seen that? Right?
Yeah. And sometimes they're not even sitting.
Yeah, and they come in, they just go, yeah, I'm just going to stand over here, yeah. And so that antalgic posture is a huge key. When I see that, I'm like, ooh, this could be a disc. So when you see that, there's a big key we're looking at. So I've got this patient comes in, I've seen him for a while, and he hurts his back, pretty athletic guy, and he's got a little antalgia, and he's a little gimpy, and he's like, you know, I had a disc bulge before. He says, do you think this is a disc bulge going on? I said, no, I don't think so, and I'll tell you why in a minute. But the biggest thing that I'll tell you is if you're suspicious of a disc herniation, there's only one way to actually validate there's actually one there, and it's an MRI. So if we really want to know if there's a disc that's there, we want to send them out for an MRI. So MRI is the most definitive evidence of a disc herniation. Without that, we're just following clinical signs to see what we're observing, and we can make a really educated guess that, yeah, you have a disc herniation, let's go validate that, and you may need surgery. Or not. So when we look at a lumbar disc, let's talk about the anatomy of the disc. What we see is in the middle we've got the nucleus pulposus, that gelatinous material, outer annular fibers holding that gelatinous material in there. We've got the longitudinal ligaments anterior and posterior, and then of course we've got your spinal canal and your foramen in here. And so the disc itself we know is avascular, it's fed by pumping action. And we actually have the pudendal nerve that goes into that disc that can give our brain feedback as to what's occurring in there. The most common causes of disc herniation are usually traumatic injury. You've compressed, you know, so you fell off the ladder and landed on your feet, you were in a helicopter and it auto-rotated down and you crash landed and you compressed all your spinal vertebra. Yeah, one of my patients, that was a fun one. And so there's that, and then there's just the typical, you have wear and tear, you know. You've lived life, you've had little slips and falls, you may have played some sports, you lifted a strain and had a couple back strains before, and then so that's wearing those annular fibers. And then over time, as they're worn down, then we get cracks in there and then that disc material can start extruding. So typically that's where most causes come from. If there's not a traumatic injury associated, then we're talking wear and tear. So on definitions, we've got two major definitions, and by the way, patients will use different words with you of, you know, oh, is this a disc bulge? Is this a disc herniation? What's going on? The typical, our terms we want to really focus on are protrusion and prolapse. Protrusion is where the disc is actually bulging out into the spinal canal or foramen. With a prolapse, we actually get material that's actually extruded out past those annular fibers. So if it's in the annular fibers, it's just a protrusion. If it's outside annular fibers, you usually have that free-floating stuff, that's a prolapse. Other things that we can have going on in the spinal canal area is we can have thickened ligamentum flavum, we can have bone spurs, or just other abnormalities going on. I have a patient, I've got an X-ray, MRI actually of this patient of his neck, and there's a disc bulge on the front side pushing into his spinal cord, and then on the back side there's something black sticking in there, and I don't know what it is, so I'm going to go see if you guys know Dr. Beverly Harder, radiologist at Western States. I'm making an appointment with her to go, hey Beverly, what do you think that is? So, but it's at the same level, but something protruding in from the backside. So be aware that there's other things that could be going and impinging on that spinal cord too. Know that most tears happen posterior lateral. Why? Does anybody know? That longitudinal ligament. Yeah, go ahead, Stephen.
Oh, just what you say.
Yeah, it's weaker there. So the longitudinal ligament is really strong, thick ligament. So on the side, it's a little weaker, and that's where that disc bulge usually has a chance to go through. So a central protrusion is rare because that longitudinal ligament is a little stronger. And then, of course, then you get pinching out into the foramen, and when you get that, you're really getting a lot of radiating symptoms usually from that patient. What I want you to know is that disc herniations, including extrusion and cord compression, can be present without the patient having any symptoms. They did a study here. They took 100 people off the street. They did MRIs. 50 of them had disc bulging with 0 symptoms. So if somebody comes to you and says, I have a disc bulge, your answer is, you might. The question is, does it really bother you? Is it affecting you? And that's my big question with my patient. You might have a disc bulging, but is it really causing you a problem? Because obviously it can be present without an issue. Not that we want it to be present. I don't want it present in my body. So our 3 cardinal signs that we want to look for disc herniations. Number 1, the first thing, the antalgic posture. They're pretty much going to be bent, and usually to one side or the other. They're usually trying to take pressure off of that nerve root by getting away from it, and sometimes even leaning into it, but usually they lean away from that nerve root that's being pressed to get pressure off of there. So we're going to see antalgic posture. There's going to be the radiculopathy, that radiating numbness, pain, weakness, tingling, hot, cold, burning sensations. We want to pay attention when they talk about that stuff. And then a positive Valsalva. You really want to go, yes, this really looks like a disc herniation. You can just ask them. If you strain at the stool, if you cough, if you sneeze, oh no, it drops me to my knees. I got to stop. I can't cough. You hear that, you're like, oh, that sounds like a positive Valsalva. Let's have fun. Let's bear down. And so one of the things that you can do for Valsalvas, a really easy way to do is just have them stick their thumb in and pretend they're blowing on a straw. Increases intrathecal pressure. Or you can ask them to bear down like you're straining at the stool. Okay? If they come back and they go, yeah, that makes my pain worse, it aggravates it, okay, there's another check that this is probably going to be a disc herniation. The signs and symptoms that may be present, you can have low back pain or not. You can have pain radiating down the extremities, one or both. Typically it's unilateral. The antalgic posture is there. There's usually going to be a hip flexor dysfunction. The hip flexor on one side is probably going to be really tight and pulling. So you're going to see that hip flexed and they'll walk with it flexed. Lower extremity sensory changes, abnormal reflexes through the knee and the Achilles, bowel and bladder changes. Big asterisk here. If they've got bowel and bladder changes, we're thinking what? Say that again? Cauda equina. Central disc herniation pressing in. This is one we want to send for surgery. On that, I hate sending my patients for surgery. I hate that feeling, just personally. So when I have to do it, it's something I feel is really necessary. I actually had a doctor, so I have an online course on disc herniations through ChiroCredit, and had a doctor comment back to me. He says, this study says that manual manipulation by chiropractors is great for disc herniations, and on this slide you said, the Cauda equina slide we're coming to, you said we shouldn't be treating these. Says, and this study shows that we're great with these, so we should be adjusting all these. And so I've got to respond to him because he's responding to my seminar. And so I look at the study he recommended, and I read down to the 6th paragraph, and it says, the people excluded from this study are people who had tumors, Cauda equina, and he just went and listed. And I said, if you'll read that paragraph, you'll realize that they took patients who didn't have central disc bulging in there. And so yes, on those, I'm going to tell you, at least send them for surgical consult. Because surgeons, I've had surgeons actually send patients to me, go, yeah, I'm not going to do surgery on you, you go get fixed first. See what you can do first. So when we look at some of our lumbar nerve root signs that are going on, if the disc may be bulging at L4, we're going to see lateral thigh to medial knee pain, numbness, a knee jerk reflex that's probably going to be a little diminished. We're going to have a squat test, which might be a little challenging for them. Again, they're probably going to already be in a semi-squat on one side. L5, you're going to look at the posterior lateral thigh and calf pain numbness. You can do the heel walk test, where your toes are up in the air. For the S1, you're going to have posterior thigh, foot, and heel. That's the one coming through the bottom of the foot. And so usually if they say they have pain going down their leg, my question is, where is it? Oh, well, it's kind of right through my thigh. Okay, we're looking maybe L4. Oh, what's back through here? Okay, maybe L5. Oh, it's down through my heel. So I get a better idea where I'm looking at potentially S1. And for S1, we can do the toe walk and then test the Achilles as well.
Can you tell me what the squat test is? I don't know that.
Just having them squat, even just squat. Can you squat? Because if they're already in this kind of flex state here and you have them squat, like they're going to squat, but they're only going to get so far and they're going to, yeah, no, I'm not done. Yeah. Or if that nerve is really shut down, they may just drop. The leg may just give out. I can't do that because my leg blows out. And they'll probably tell you anyways. So spinal manipulation is contraindicated with Cauda-equina syndrome. This is from the WHO, World Health Organization guidelines on basic training and safety in chiropractic. As you know, with the Cauda-equina syndrome, what we're having is a central disc herniation coming right into and compressing directly into the spinal cord at that L5, S1 level, typically. What we're going to see is that we're going to have saddle paresthesia. There's numbness through their genital anal region. Yeah, when they come in and they tell you they're numb here, red flag starts going off in my head. Oh, wait, why are you numb there? Bowel and bladder changes. Increased or decreased tone are something that we want to definitely look at. Typically, it's usually a decreased tone. I got to wear diapers now. I can't control my bladder at all. I'm embarrassing myself when I'm in public. If you hear those statements, you're like, red flag. Bilateral radiating lower leg pain and or severe low back pain. Again, the pain may not be present. They might just have this numbness and these bowel and bladder changes. But if you got all three of those, think Cauda-equina, go get the MRI. If you do nothing, if you don't even want to send them a surgeon, at least send them for an MRI to validate whether or not that's actually going on. And if it's not that, there may be a tumor or something else going on. So look at all that. There may be an infection going on. So disc herniation locations, where do they occur? 95% of those occur in the L4, L5, and the L5, S1 disc. By the way, I will talk a little bit about cervical disc herniations in here, and I want you to know that the stats for disc herniations are still 95% are lumbar. The other 5% tend to be a little cervical or other places. I have seen actually one thoracic, which is a really interesting case, really tough to get results with. In the disc, cervical disc, we're typically C5 disc, C5, C6 disc is the number one that's usually in the cervicals. So if you have questions on anything related to cervical, let me know too. The inferior nerve root is what's effective. So if it's the L5 disc that's bulging, it's the S1 nerve. Sciatic nerve is the most commonly affected nerve, although you can get the obturator and some of those others potentially affected in there some. Most disc herniations happen in the 30 to 40-year-old age range. So when I have a 70-year-old come in going, do you think I have a disc herniation? Probably not, because if I look at you and you look like you probably, your discs are pretty dried by now. So the good news is you get older, less chance for disc herniation. Although it does happen. I've had some, but. And males are more common than females. Differentially diagnosing the patient. What are some of the things we want to look at? What do we want to pay attention to? So in our physical exam, just looking at if the person comes in, well, I've got back pain, and they may have antalgia, let's go, they've got antalgia, they've got back pain. How do we distinguish what they're feeling? So we've got mechanical pain. That's pain when they actually move or put pressure in and through a joint. You've got discogenic pain. By tractioning or compressing, we can usually distinguish a disc issue. And then myofascial pain, more muscle fascial type pain, and that's going to be more contractile pain. When they contract or when they stretch, they're going to feel more of that. Imaging studies, again, so if we just take an x-ray, some of the things just to define, this patient's low back pain, get an x-ray, see what's going on with them. So do we have spondylosis, spondylolisthesis? Stenosis is a big one that can really mimic disc herniation. So if you've got somebody, they've got something going down one leg and back pain, just an x-ray is a really good thing just to rule out stenosis, whether it's central or foraminal. And then obviously if there's an abscess, myelitis, hematoma, tumor, etc., or even aortic dissection, your blood test, if you do blood tests, just giving you information that's out there, myocardial infarct and osteomyelitis are going to show up in your blood test. So if you do blood testing, know that those are things that you want to differentially diagnose. Valsalva maneuver is going to increase interspinal pressure, which aggravates the disc herniation symptoms. I already showed you this video is the guy blowing. How do you guys test Valsalva? Anybody do something different than that? We've talked about the bearing down and the blowing. Anybody got anything else?
Cough.
Cough. Anybody scuba dive? When they go to clear their ears, it's a Valsalva maneuver. Increases intrathecal pressure. Okay, so healing rates for the lumbar disc. 50% of the disc will recover in 1 month, says this study, and most will recover within 6 months. Now, this is done on lumbar disc. The disc herniations in the cervicals may be a little different. Well, obviously have a little more mobility, probably a little different pressure forces that we get than we get in the lumbar. But I would imagine that the healing times can't be too far off on that. So like you were saying that your disc, you didn't really do much and it got better on its own. So most of these, like I say, if we do nothing, they should go away. So it's this good news to tell your patient. You know, yeah.
Is this just the natural history? If you don't touch the person, this is what we're talking about?
That's pretty much what this study did, is it went through people who went to see, you know, a doctor for disc herniation and no treatment was rendered and they still got better.
I always wonder what they mean when they say recover, you know, like.
Thank you.
You know, like
Right.
the inflammation's gone, they're non-antalgic. But I've seen that same thing with frozen shoulder. They say naturally recovers, but what happens usually is people have limited mobility and they may not have pain, but they still have, you know, situations that we would work with, you know.
You're right. Thank you. That's exactly right. So I think what they're looking at is the symptoms are gone.
So they're not antalgic.
But they're right. They're not antalgic. They're not complaining of symptoms anymore. But are they better? Probably not. And is the disc bulge still there? Probably. It's just not radiating, inflaming, irritating, is my guess. The good news for us is, this is if you do nothing. We don't want to do nothing. We want to do what we do, which is really great. So we can speed this up even faster. But the nice thing is just this is great information to tell your patient, you know what, if I did nothing to you, Mrs. Jones, you're probably going to recover from this within a month to 6 months. But the good news is I think I can make that even faster. And hopefully we can even change your pain today, which I think we should and we can. So treatment options, what can we do? That's not non-surgical and non-pharmaceutical. Well, obviously we all know that spinal joint manipulation is huge. What we want to look for and be cautious of is taking the chance of increasing more disc pressure or causing damage. So how we approach the disc, how we treat that person. We can approach them with something that may injure them, or we can approach them in ways that are easier and gentler. So some of the things we can do that obviously are pretty non-traumatic. Instrument adjusting is not really going to be a super thing. It's going to create a lot of extra force in there that we can actually use to apply and make some nice changes with the patient. Soft tissue manipulation or massage, traction and spinal decompression. Obviously we want to decompress those discs, get pressure off those nerves, so that's a huge therapy to use. Braces and supports, exercise therapy. Some PT may be beneficial for using ultrasound, electrical stim, laser light therapy. And then if you've got extruded material, nutritionally we can kind of go to approach to attack that by using proteolytic enzymes. That stuff is floating out there, and if we can add more proteolytic enzymes, we have a better chance of reabsorbing that material. Anybody have anything else to add on that line? Some of you are probably way more brilliant in nutrition than I am.
It seems to be pretty effective, but it has to be a pretty high dose, and you have to watch out for contraindications like ulcer and other things like that.
Good. Did you guys hear that? Good.
And you want to be sure not to take it with food.
Yeah, right.
Right.
Okay, so can we prevent disc injuries? Yes and no. There are things we can do to be proactive. For example, how we sit. If we look at disc pressure from different postures, from sitting with your back relaxed, really low pressure, to sitting forward, to sitting upright and lifting a weight. the disc pressures increase dramatically with those differences. And the same thing with certain standing positions. When we're in standing flexion, a lot of disc pressure. So we want to watch out for compression going on and also pay attention to core muscles being in a guarded hypertonic state, taking the upper body and compressing it down into the lower body. And now that's adding compression, more compression, just by them standing or even laying. If these things are too tight, it's creating excess pressure. Swelling. When we sleep, obviously we're taking pressure, gravity out, and so those discs get a chance to reabsorb more water and they get bigger, they fill up, right? They swell. And so what happens when the patient first wakes up in the morning, what do they feel? I'm in horrible pain for the first 10 minutes, half hour, whatever. And as that disc starts compressing more, it shrinks down a little more. Now it takes more pressure off of the nerve that's causing the pain. So if your patient is telling me, oh, my back pain is horrible in the morning and I can't even hardly get out of bed, could be because that disc is all swelling. So one of the things that you can do is have them while they're laying in bed just kind of start shifting and moving a little bit, just to start creating some compression too. Shearing. So obviously cross-plane motions, you know, the good old stretch and bend and, oh, now I can't get back up. Yeah, those cross-plane motions. The loading forces, the shearing stuff. We want to watch out for anything like that. So we want to make sure that we're talking to people about good, proper body mechanics. Obviously when you're lifting, we don't want to be lifting with our back, but with our legs. I talk to my patients about when you're sitting, change your posture. So if you're sitting doing your work on your computer, whatever, lift a leg, put it up on the toe, open it, shift a little this way, shift a little, don't stay static, move. Get up and take breaks. Definitely for your upper neck too, free all that stuff up too, but get up and walk around. Know that you want to lift within your limits, and then definitely if you're doing strenuous yard work, relax and take a break afterwards. Don't jump into the next project or go climb the roof or things like that. And then obviously physical fitness, keeping them healthy, keeping them strong and flexible are things that are going to be preventative, and also some rehabilitative stuff we can do. On their anatomy, things we want to look at today, we're going to look at the bones specifically, the lumbars, the sacrum, iliacs, and the femurs are the main bones that are going to be our focus for this area. Okay. On the muscles associated with all that, in the lumbar spine we got spinal erectors and the lats, the latissimus muscles, attaching from the arm, come down and attach into the spinous processes all the way down to sacrum and at the top of the SI joint. So if a lat is a little dysfunctional, it can create a lot of distortion into that low back. Obviously your core muscles, we talked about those already being an issue. Core muscles, your ab rectus, your obliques, your transverse ab, quadratus lumborum, and psoas muscles. Okay, the Christmas tree muscles. Psoas muscles attaching from the anterior part of your lumbar spine, coming down, inserting into the inner thigh. Quadratus lumborum coming from the bottom of the ribs and attaching to the transverse processes, and then coming out into the top of the pelvis. What I want you to know, the psoas muscle, the only muscle in the body that attaches directly to your lumbar disc. If you have a disc issue, what do you think's going on with that psoas? A little louder.
Gets contracted.
It's going to be contracted, it's going to be guarding, it's going to be trying to protect. Now if this psoas muscle is attaching to disc, and the disc is a little irritated, and now that muscle tightens more, that disc kind of stands to reason it's going to be even more irritated. In the pelvis, we have the iliacus muscles, the sartorius, tensor fasciae lata, quadriceps, glutes, and piriformis. And all of these, again, I want to go through some of this to let you know that we have muscle guarding and splinting that's going to happen. Disc injury is typically going to have some type of trauma. And so therefore, the muscles are also going to guard. And so the more guarding these muscles are doing, the more compression we're having into the disc. So the more we can relieve this tension, the more we can relieve disc compression. So looking at that psoas muscle, again, it attaches to the lumbar bodies and the disc, and then runs down, attaches into the inner thigh, the lesser trochanter. It's your hip flexor. It flexes and externally rotates. If we've got disc herniation going on, and I told you the antalgic posture, and the hip flexor dysfunction, that's that psoas locking down in there. And so you're seeing them come in like this. Have them try and stand up straight on their good leg no problem. They can keep that bent. Have them stand up straight on the other leg. It won't go. And they probably can't stand on that leg. They'll probably just drop right out. In the iliacus muscle, this is the muscle that's lining the inside of the ilium, and then it runs down, combines with the psoas to attach into the lesser trochanter, also a hip flexor. And then the sartorius is actually at the anterior portion of your anterior superior iliac spine, and then runs down into the medial aspect of your tibia, also a hip flexor. So if you see this person in this flexed state, those three muscles probably are all in a little bit of a guarded tone. For your abdominals, rectus abdominals, how high up does ab rectus attach? How high up does it go? Anybody?
Fifth rib in cartilage.
Where?
Fifth.
Fifth rib, way up high. Real quick side note, had a patient, female patient come in talking about left chest pain. So I'm looking at her pectoralis muscles and nothing, test strong, no pain on palpation, but there's pain right at this corner right here. So like, this is really weird, she's got chest pain. And so I just went, okay, wait, ab goes up there, and I pushed up on her, and she goes, that's it right there. That little move took all her pain away. So ab rectus can actually cause you pain way up here, just an FYI. Runs down, attaches all the way to your pubic bone. And if ab rectus is tight and guarded, guess what it's doing to your rib cage? It's taking the ribs and jamming them down into your stomach. How well is your digestion going to work? Might be a little challenged. And it's going to take the pubic bone and pull it this way. Okay? So if you can't see that, pubic bone is going to be pulled up. This is going to be shifted down, and now you're going to have a lot of pressure and pain where? Right at that belt line. The patient's going to go, I hurt here because this is too tight. They don't feel pain here. They feel it here. This is where the joints are.
Till you touch them.
Till you touch them. Yes, and then you touch them, they go, oh, I didn't know that hurt. Okay, your obliques attach to your ribs both at the border and on the surface, okay, or if you will, at the bottom inferior borders of multiple ribs. But when you're palpating, pretty much you're going to feel that over the surface of the bones. And then, of course, runs down and attaches to the crest of the iliac. Transverse abdominal, deeper. Transverse abdominal is a big fascia sheet, and this is the primary core muscle. If this one is not firing right, the rest of them are out of order. And the person has some really challenge. And by the way, all this causes back pain. This is all tight. The pain they feel is here. Transverse ab is a sheet that attaches from your rib cage all the way around to your spine, to your pelvis, to your pubic bone, and the muscle fibers go from under your ribs here and down inside towards the inguinal ligament. So we want to look at all that stuff. How does the transverse ab, what does it do? Does anybody know? It compresses the viscera, so it holds everything in. And if it's the primary core muscle, before we do any move, it's got to stabilize. It's our stabilizer. And so if it's distorted, there's a lot of challenges that person's going to have. Quadratus lumborum, attaching from the ribs and transverse processes down on top of that iliac crest. Real quick, easy evaluation. Again, this person's going to be a little antalgic to one side. If you can have them lift the hip to the rib and compare. With a disc herniation, they might not be able to do that at all. But if you got someone with low back pain, just challenge them. Just have them lift that hip and see if they can just lift one at a time. And usually they're going to go, I can't do the one, or there's pain when I do it, or it's more challenging. And then you know you've got some quadratus lumborum issues going on. And again, that's the lumbar spine and your iliac crest going on. Gluteus max, attaching from iliac crest and posterior sacrum, and then runs down and inserts into the posterior tibial band. If you look at where the ischium is, you're probably going down about 2 to 4 inches and lateral. And that's where the insertion point is. And by the way, gluteus maximus is the most powerful extensor. If it's weak, that person won't be able to stay vertical very well. The body's just going to pull it over. Those flexors are going to pull too much. Piriformis also, so we've got radiating symptoms. Patients talk about back pain, pain in my rear end, pain running down the back of my leg, pinching on the sciatic nerve. Sciatic nerve runs over, under, or through piriformis, and so if this piriformis is in a hypertonic guarded state, we're going to have some issues there which may mimic disc herniations. Also, with a tight guarded piriformis, what can we notice in the person's gait? The duck foot. Yeah. So if you see somebody walking and one foot is very straight and the other foot is rotated out, oh, it looks like you got a piriformis issue. Always fun to do people watching and go, oh, look at your gait. Does anybody else do that? Okay. I know you do. You're smiling. You can't help it. Spinal erectors. Spinal erectors, for our purpose today, we're looking at where they originate from the sacrum and the medial iliac crest, and as well as the spinous processes, L5 to T1, T11, and those are going to go up and insert into the ribs and transverse processes of lumbar and thoracic vertebra. The action is to extend and laterally flex the spine. So again, if we want to evaluate the person and see how well this is functioning, can they stretch that muscle open? And so typically if they're stretching forward and they're talking about, I'm having back pain when I stretch forward. Okay, where's your back pain? Here. Okay, bend forward. So if I have the person with their knees straight and they're bending forward and they go, oh, back pain. I'll go, good, come back up. Now bend your knees. Now bend forward. Oh, I don't have any back pain. What just happened? I took their hamstrings out. They bend their knees, the hamstrings are no longer creating restriction. Now they don't have the back pain. And so I can go, oh, your pain's not coming from this area as much as it's probably coming from the hamstrings. With the lat, huge, huge muscle. Attaching from the arm, this muscle is your chin-up muscle. So it's pretty powerful. And by the way, every time you bend over and pick stuff up, that's your lats working too. So it really works a lot with pulling into your sacrum, your lumbars, because it's attaching to the spinous processes from T7, T8 all the way down. Little talk about muscle physiology. So we got a bunch of terms we use with muscle physiology. Tone, spasticity, cramping, splinting, guarding. What do all these mean when we have a conversation? Tone, just tone in general, is the continuous residual muscle tension in a resting muscle. By the way, the picture you see, we have all kinds of different muscles throughout the body. And so we obviously want the tone of all of them working well, especially your heart, right? Might want that working good. Spasticity, excessive chronic tension or this hypertonic state, okay? And I want to distinguish spasticity, because we use that term to describe what we palpate, what we feel in a muscle, versus a cramp. The patient goes, oh, I'm cramping. And the cramp is what the person is feeling. They're like, oh, that muscle is locking down. Usually caused by dehydration, electrolyte imbalance, hyperflexion, holding it too long or too intensely, fatigue, or hypoxia. And in splinting and guarding, I'm using this because this is a reaction. Splinting and guarding is what your brain is telling your muscle to do. It's a protective, involuntary contracture intended to protect an injured area from further injury. It is not much different from hypertonicity. We can describe it the same thing. Just remember, this is what we palpate. This is what the brain's doing. At least that's in my head. If anybody has anything to share different than that, I'm all game.
Usually splinting is a little more intense too than spasticity.
Yeah, and so we can use different grades for all this too, and we'll talk about different grades on these. I also want to talk a little bit about muscle memory patterns, because again, if this person's coming in, they've had an injury, and they've got a disc herniation, and they've got this antalgic posture, and they've got this hip dysfunction going on, their muscles are all going to be in a guarded protective state. This brain is telling them splint, guard, and so what's happening is you're getting nociceptors, or your pain receptors are producing that guarding reaction. Okay, when we've got an injury or stress to the disc and nerves, that guarding now is going to lead to an abnormal position and limited range of motion. I can't go. Then there's also going to be a local tissue response that's going to go on, and it's going to reinforce that pain receptor activity. So it's a negative loop. This person's stuck, and they can't really break that loop, and that's the challenge. Long-term challenge with that is that that's going to lead to connective tissue changes. We get degeneration of the disc, degeneration of tissues, cartilage, etc. We get ossification of fibers as well, and osteophytes can also form. Stretching injured tissues may re-stimulate that nociceptor activation. So yeah, just stretch that out real good, or not, because it might aggravate everything. So when we stretch, we want to make sure we go nice and gentle and easy with stretching. Yes, ma'am?
Are you talking about the muscle memory existing beyond after the inflammatory stage is over?
Well,
What are you
there's
talking about
that
disc
too. It's all there through acute, and if we don't address it, if we like we talked earlier about the disc, if we don't address this stuff, it'll get less, but it may still be there kicking in the background. What I'm referring to specifically for this situation is person was injured, let's say last week, they fell, landed on their rear end, and now they've got this back pain, and we'll say they have a disc herniation going on, positive Valsalva, antalgic posture, they're coming into you, and since they've been in that state for a week, the brain is saying, stay in that locked position, because if we do this, that's too much pain. So we're just going to make you stay here, is what the brain's doing. That memory pattern is locked in there, telling the patient stay there.
sense, regardless of what's going on locally, to generate that?
Yes.
Sort of has a life of its own.
Yes, yeah, exactly. It takes on a life of its own. And what's really bad is, you know, everybody in this room pretty much works with patients, and you know there's an emotional attachment to pain as well. And so that also comes in there too. Good?
Good. Just
Yeah.
curious, you know, you've got this sighting from 1990. Do you just happen to have more things that you've seen on that? Because I obviously see it, and I think it's very real. It's just kind of finding substantiation for that. I'm curious, because
I have
I
six
hear a
pa-
lot
I
about
have-
muscle memory and, you know, massage therapists talking about it, and again, I think it's a real entity. It's just kind of
It's huge.
how to, you know, who's doing work on that, I guess, research.
Sometimes we have to kind of look to what the cause of all muscle splinting and problems is, and that really is that firing and the recurrent meningeal nerve causing, you know, spasticity in the muscle. So what we're doing is that the actual injury in the disc is the focal point of all of these muscle reactions, and the splinting of the guardian and all of that stuff. So really, for us, focusing on that disc and decreasing inflammation and working with all the things we can do, that's going to help all these other things. Muscle memory is a situation where if there is no offending factor, the muscle continues to hold on to that splinting and guarding, and that's when massage and stretching and working on the muscle really is effective. So when the initial, you know, mechanism is taken away and the muscle still reacts, then that's when we can really work on the muscles.
So can I take that picture, because I like that picture, but I want to show you the back side of that picture.
Mhm.
And so the back side of that is we've got the person who's got these muscle memory patterns. They're a runner, and they've got a foot that's a little off, and now they is throwing that hip off for years, and now that leads to the disc injury.
Yeah.
And so there's that memory pattern too.
Yeah.
So the muscle memory patterns are all there, and we're going to definitely talk more about how we alter those memory patterns. That's my big thing. Yeah, we all know it's there. What can we do with it?
It's a two-way street.
Yeah, yeah. Chronic muscle hypertonicity is the result of trained protective muscle memory patterns. Like I said, the runner with a little foot imbalance, now the hips and the low back are all going to be a little altered. And so for us as clinicians dealing with patients, what we can tell the person is, Mrs. Jones, you've got a muscle memory pattern that you've come into my office with. And what we want to do is we want to change that muscle memory pattern, which means we might need to repeat seeing you to get these muscle memory patterns unlocked. It may not happen in just one visit. So this is your justification of why Mrs. Jones needs to keep coming back, because we've got to alter your mechanics. We want to change what's going on so that we don't keep going in this pattern and keep aggravating these symptoms. So what do you see? When we look at an MRI, how many of you look at MRIs at least a couple times a year? Good, okay, most of you, yay. How many of you like looking at radiology? Okay. I really like looking at pictures, just so you know. So one of the things we want to look at is the bony alignment. And then the disc height, where we might have a disc herniation, which level, which nerve root is affected, associated symptoms, and a patient's age. So with what we've already discussed today, what can you already determine from this picture? Let's talk about bony alignment. What do you see? What do we see up here? It's pretty straight. That's the lumbar spine. It should have some curve, right? Yeah, okay. And then, so we know the bony alignment, but when we look here, this might actually, I don't know how well you can see that from your distance, but this, either it looks like we have some extra bone out here, or this might actually be shifted off a little bit if I'm looking at the alignment in those. So there might be a little distortion going on there. It's not a huge distortion, but that may be some. So looking at a bony alignment. Looking at our disc height. Good, 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 good. Not so good. Pretty good. And of course, so what level are we at there? Okay. So which nerve root is that? L5. What symptoms do you expect to see? Let's talk about what radiating symptoms do you expect to see?
In the thigh, top of the foot, or side of the foot.
Yeah, so lateral, lower leg, top of foot, lateral thigh to posterior thigh. Patient's age. Who's most likely to have a disc herniation?
37.
Thank you. Good. Between 30 and 40. Male or female?
Boy.
Most likely boy. Good.